Ted's talked about how a lot of that has been helped on the clinical care delivery side. But as James pointed out, if there's 10 to 30 middlemen between my company and the patient who gets the drug, isn't that a crazy supply chain? And so if we want to do what Mike said, which is get to the point where we're all in agreement that we have some shared responsibility to fix this issue, I would like, or I would prefer, that our federal overseers and masters help us in this regard, because some of the rules tie us up. Even some of the, anti-kickback rules, that may need safe harbor relief. There's a lot of innovative things that can be done that get grit out of the machine and allow us to get much more efficiency in the same way that automakers have gained efficiency, refrigerator makers have gained efficiency, in ways that we need to actually get better data flow instead of fragmentation. On the consumer side, Experian and LexisNexis know exactly how much you, Alan, can spend on a refrigerator, but they don't know how much Mike and Bruce's patients can spend. So I would just put a plea in for some of those other things that we're very good in this country doing, that people in the rest of the Western world envy us for, about being innovative in reducing some of the costs that are not about the just price of a pill.
Yeah. This value conversation does open the door to rethinking about what it is we're trying to achieve with healthcare, and that's exciting for patients in particular, because it gives us a chance, hopefully, to be at the table to say, all right, well, hey, as long as we're paying a lot now and we're the ones that are supposed to derive the benefit from the care, let's talk about what we value. And to your point, Mike, I think we don't have that information now in a real world way that really allows us to be as adaptive and as nimble with that patient. So that's the problem that we need to fix, is how do we actually deliver data in a post-market world. The challenge is, if these products are so expensive out the gate, it's expensive to do that, just throw it out there in the marketplace and see what happens to it. So my gentle criticism of all the stakeholders is, while we're talking about value, we're not really trying to figure out how do we create a new system that really understands and delivers value to the patient, and what are the gaps that we need to fill to be able to do that. Instead, we're creating tools based on the old way of doing things, in the old notion of, providers and payers and everybody get together and decide what is value for the patient, and having the patient kind of there at the table to talk about it, and the aggregate of those decisions should reflect then net social value. From an insurance perspective, as a patient, I'm not having money taken out of my paycheck, and I'm not putting any money out of co-insurance and co-payment in order to give it to the insurance company to try to generate some sort of net social value, nor am I giving it to the drug companies to do that either. It's my plan, it's my coverage. I'm doing it because it's supposed to provide coverage for me to be able to get treatment for what I need to get better and to protect me financially. That's a different, in the head of a patient, that's a different value proposition for insurance. I'm not thinking of insurance as a way to increase net social value. I'm thinking of it as a way to make sure that it's my plan, I'm gonna have coverage. And what we're finding now is most people don't have coverage, they're underinsured. So we need to rethink that in and of itself, is, if we're really going to put patients in that position of not being able to really afford their care, at that basis, then we've got to give them more information about how to make smart choices and what are the true risks and benefits and costs to the choices that they're going to have to make.